So the topic is, human growth hormone, is it adult growth hormone deficiency or growth hormone resistance that's a clinical marker for degenerative disease? Growth hormone is a polypeptide. It's produced and secreted in the pituitary gland, and it's converted in the liver and other cells to the active ingredient that's circulating in the blood that supposedly is stable, called insulin growth factor 1. This is a father reading to his children saying, what's the big deal? A little bovine growth hormone, as they sit there looking like cattle. And the reason I put this up is it's important for us to not just look at growth hormone as it relates to the aging population, but look at it as it relates to the children that we're raising on hormone-laden food. So I put this up because we're allowing ourselves and our children to get hormones in other ways other than through medicinal purposes. We're getting it in our food. And I think we need to understand that if growth hormone was such a bad hormone, we wouldn't see the benefits that we see from it. The hypothalamus is the major control of human growth hormone. It's produced through a feedback mechanism that incorporates growth hormone releasing hormone, as well as somatostatin and IGF-1. And if you want to see how that works, the pituitary gland produces growth hormone, but there are numerous ways it can be suppressed. It can be suppressed through levels of somatostatin from the hypothalamus. It can be suppressed directly from IGF-1 levels so that the pituitary no longer pumps as much growth hormone as it would, and it can be stimulated by growth hormone releasing factor. Now, it's a pulsatile hormone. First of all, it's a polypeptide. It's not like a lot of other hormones. And it pulsates most often after exercise and at bedtime, early, especially in the early period of sleep. So it's a pulsatile hormone, and if you look at the pulsation of growth hormone in the top slide, you'll see that the level of IGF-1 here is the level is 113 when the average growth hormone level is 0.7 micrograms per deciliter. When it's 1.7, the average IGF-1 is 162, and when it was 2.4, the average IGF-1 level was 239. We don't know what the normal IGF level is. We think from the clinical statistics that it probably should be somewhere around 300 to 400 for optimal health, but we don't know. There's 3 ways to determine adult growth hormone deficiency: an insulin tolerance test, arginine growth hormone releasing hormone, which is a stimulant of growth hormone, and then glucagon stimulation test. And I'll take you through that. The ITT, like all growth hormone stimulation tests, suffers from substantially from reproducibility. The ITT is not as accurate. It used to be thought by the endocrinologist as a gold standard, but the truth is it isn't as gold a standard as we would like, because it lacks specificity, it lacks sensitivity and specificity, especially in adults, maybe not in children, but more so in adults, and it is dangerous. Profound hypoglycemia has been reported and has been associated with cardiac arrhythmias and maybe even death. So, although IGF-1 may not, this is again what we know, although IGF-1 may not be the perfect test for the diagnosis of adult growth hormone deficiency, it may be sufficiently informative in many cases to warrant using it on routine basis. IGF-1 also has a role in monitoring the safety of patients on growth hormone treatment. So we'll talk about how that is in a minute. But in the same article in 2004, no laboratory test has sufficient diagnostic sensitivity or specificity to serve as the gold standard for the diagnosis of growth hormone deficiency in adults. Therefore, test results should be interpreted after assessment and risk for growth hormone deficiency is determined on clinical grounds. In other words, we don't have a way of identifying, a good way of identifying if there is such a thing as growth hormone deficiency. But according to the Society of Endocrinologists, we're supposed to use a stimulation test, and if you read the insert for growth hormone use, you have to do a stimulation test before you can incorporate in adults the use of growth hormone. I can tell you that the arginine growth hormone releasing hormone, which is no longer commercially available in the United States, the ITT is too risky, so the glucagon stimulation test is basically the test that is used. The aim of growth hormone replacement is to achieve normal, metabolic, functional, psychological consequences of adult hypopituitarism associated with adult growth hormone deficiency. There should be an appropriate replacement of the other pituitary deficiencies if they exist. So this may be a multifactorial problem. You know that LH controls testosterone, and we know that low testosterones are associated in the aging population. We heard from Ed Lee today about the thyroid and how important it is not just to look at when the TSH goes up, but look at free T3, look at reverse T3, and understand that this is a complex mechanism. And you heard just recently about the benefits of testosterone. They all have an effect on metabolism. All of them. All of them increase muscle mass. Obviously, the thyroid has a profound effect, so you can't just look at one part of this and say it's a matter of balancing all the pituitary hormones, all of them. So while adult growth hormone deficiency may be an isolated situation, the conclusion of the Growth Hormone Research Society was consistently these studies have demonstrated that adults with growth hormone deficiency are both physically and psychologically less healthy than the age-matched peers, and that growth hormone replacement results in substantial and sustained benefits. The best marker, remember about the myths, remember about the opinions. The best marker for growth hormone action is IGF-1 in the serum. Read that carefully. The best marker for growth hormone action is IGF-1 in the serum. Remember opinions. Values should be kept in the age-related normal range. For those of us who have been using growth hormone, as it becomes more and more of a sophisticated test, the normal ranges change based on the technology used by the laboratory. So we don't really have normal ranges for health, but it is pretty much accepted that a growth hormone or an IGF-1 level below 200 or below 150 is below where you'd like to be. And certainly very few people argue that when it's below 100, it represents a true deficiency. Here's the signs of so-called growth hormone deficiency. And if they sound at all familiar to what you've heard before, increased abdominal fat, decreased in lean body mass, especially in strength, thinning of the skin and cool extremities, decreased psychological well-being and energy, poor social interaction, elevated low-density lipoprotein, decreased HDL, increased C-reactive protein and other inflammatory markers, increased fibrinogen and plasminogen activating inhibitor 1, abnormal indices suggestive of insulin resistance. Now, there's very little distinction between all of those symptoms and insulin resistance. The signs and symptoms are abnormal body composition, reduced lean body mass, increased abdominal adiposity, reduced lean body mass. That's not a typographical error. It's just more important to say it twice because I screwed up. I didn't read my slides. Reduced strength and exercise capacity and impaired psychological well-being. Just think about your patients as they age. Think about what's the number one cause of debility in people over the age of 70. What is it? Yell it out. It's a fall. It's an orthopedic injury. The number one cause of morbidity and mortality in the aged population is a fall. The cascade then is they throw a pulmonary embolus, they develop a myocardial infarction, they have some complication of their sedentary lifestyle. The thing that got them there was weakness, lack of muscle activity. You're all going home at some point in time. How many are flying home? Good. Look at the people on the airplane and see how many of them need assistance to get in and out of a chair. Lean muscle mass is important in the elderly population. Sarcopenia may not be a disease, but it's a debility. Vitality and energy, isn't that what you want? You know, you spend your whole life working, and then you retire for what? So you can't get out of bed? Switch your paradigm. Realize that not everything we do has to prolong life. Especially there is no one that doesn't want productive life. No one. These people are overweight. They have dry skin, cool extremities. They don't tolerate temperature well. They don't sleep well. They have decreased muscle strength. They're depressed. Of course they're depressed, for crying out loud. They can't move. We look at growth hormone levels in this scientific world as having a level of 3 micrograms per liter. That's the production the pituitary has to put out. And if it produces 3.5, you're not deficient. If it produces 3, you're deficient or less. But if you're 3.5, you're not deficient. It doesn't matter that your elevated lipids and that your IGF-1 level is low. Those things don't matter. Consistently, these results have demonstrated that adults with growth hormone deficiency are both physically and psychologically less healthy. The best marker of growth hormone is IGF-1 over and over again. This is what the literature says. Here's the science behind it. If your growth hormone levels are high, your IGF-1 levels are high. You want to look at the dependability, the relationship between growth hormone and IGF-1. Granted, this is an older study, but all of the newer studies say the same thing. You want to keep the optimal levels of growth hormone where there's a low risk of growth hormone deficiency, and that means keep the IGF-1 levels up. Keep the IGF-1 levels up, because IGF-1 is what growth hormone is active as. You need the IGF-1 to be effective. This shows that sarcopenia and mortality are directly related to IGF-1 levels. IGF-1 levels. Here's an interesting ponder. Patient X has the signs and symptoms of growth hormone deficiency and has an IGF-1 level of less than 125. So his endocrinologist was told, so the patient X was told by the endocrinologist, this is a normal level, and he doesn't warrant any further investigation. Patient Y has similar signs and symptoms. IGF-1 level is 89. Patient Y fails an ITT test, insulin intolerance, is denied therapy. But patient Z has the same IGF-1 level, passes an ITT test, and is allowed therapy. His IGF-1 level is used to titrate his growth hormone dose to be maintained so his median is 290 micrograms per deciliter. So the endocrinologist is saying at 89, you're abnormal, but at 139, you don't need any evaluation. But when I'm going to treat you, I'm going to bring your IGF-1 level up to 300. At the talk, an endocrinologist describes the paradigm of treating the upper half of the IGF-1 levels of replacement patients. Patient X, primarily care physician, hears the talk and says, well, if 125 is normal, then why don't you titrate your growth hormone doses to 125? There's the opinions. When we treat people, we're always optimizing their levels, but we're waiting until they get so friggin' sick. You know, we used to talk about TSH. Ed Lee talked about a TSH level of 2.5. Does anybody remember when you had to have a TSH of 20 before you were considered thyroid deficient? And now 10, and now 5. So is the IGF-1 level too low, and is there a deficiency of growth hormone in these individuals? So IGF-1 levels are adequate for the evaluation of growth hormone secretion. IGF-1 levels are well accepted as treatment markers, and IGF-1 has been accepted to be a marker of disease risk in the aging population. Here's the way growth hormone looks. Up to the age of 20, you're producing a lot of growth hormone, and your IGF-1 levels are reflective of that. After the age of 20, precipitously your IGF-1 levels begin to fall. Somewhere around the age of 35, they begin to fall below 300. And they precipitously fall throughout your life until the lights go out, but there's no association between IGF-1 and death. Bull. Why would we want to make people feel better? Why would we want to give them a longer, better life? I don't think I want to practice medicine if I'm not making them feel better. I think I want to know, how do I make them healthy as I possibly can. I'm not looking about prolonging their lives as much as I am. This is the signs of a rapid fall in growth hormone. Decreased cardiac endurance, decline in mood and well-being, gain in abdominal fat and strength, diminished skin thickness, glucose derangements, insulin resistance, decline in sleep, decreased body, and these are the benefits of replacing it. Increased body fat, increased bone density, increased aerobic capacity, immune stimulation. There's two breakdown products. When growth hormone is stimulated, you need to look at both IGF-1 and IGF-BP3. The ratio between IGF-1 and IGF-BP3 is important. And one little trick that we've learned over years and years and years of growth hormone therapy is if you give growth hormone and the IGF-1 goes up and the IGF-BP3 goes down precipitously below 3, watch out. We don't know why that happens, but we do know that there may be a reason why you want to stop growth hormone therapy. So when you give growth hormone, IGF-1 should rise, and IGF-BP3 should either stabilize or go up slightly. But it shouldn't precipitously fall. If it falls 1 point from 4 to 3 micrograms, watch out. But all of these patients will benefit from mood elevation, better sleep, faster wound healing, improved. Why would we want to use this stuff? It's ridiculous. The early studies showed that, Rudman in the 90s showed that if you kept the IGF-1 level between 160 and 500, you improved lean body mass, lowered body fat, improved the skin thickness. All of these studies have been repeated over and over again, and they all show the same benefits. In 2002, Blackman showed improvement in growth hormone, improvement improvement in body mass, lean body mass, strength, energy, etc. But there were some complications. But they used extremely high doses of growth hormone. Very few of us use 21 units of growth hormone a week. The average growth hormone dose is about 7 units a week. Remember that 3 units of growth hormone equals 1 milligram. So you want to keep your dosing around 0.3 to 0.4, 0.45 milligrams a day. We no longer do it intermittently, like 3 days a week, because growth hormone's pulsating every day. We do it every day. So the average dose is around 15 units every 2 weeks, roughly. Women will require more growth hormone than men. That may or may not also be a myth, but it seems to be that women require more growth hormone than men to raise their IGF-1 level. But remember, one of the things that affects IGF-1 is estrogen. So estrogen will decrease IGF-1 levels, and testosterone will increase IGF-1 levels. This is a 10-year study that showed that there was an increase in lean body mass, improved cholesterol, carotid enamel thickness was greater in the study group, and improved memory, cell-to-cell communication, IGF-1 levels improved. This shows that there was no real known benefit on congestive heart failure patients. There's a meta-analysis. It's really difficult to take a congestive heart failure patient with a low ejection fraction because one of the side effects of growth hormone is increase in fluid retention, and so edema may be contributing to not getting as good a result in heart failure patients. We, however, have found and have done a study retrospectively on testosterone and growth hormone, and in cardiac patients, actually, there is an improvement in cardiac patients, but be a little bit careful if you're going to use growth hormone in anyone with congestive heart failure. Make sure you're doing that in conjunction with a cardiologist who understands the physiology of growth hormone. It may not be quite as easy for you to manage them as it would be if you had the assistance of someone who's expert in that particular field. I'm going to go through the long-term benefits of growth hormone on the heart are unknown. There does not appear to be any increase in hypertrophy. It does not increase blood pressure. It does not cause increase in congestive heart failure. And there's some recent evidence that in idiopathic cardiomyopathies, growth hormone may be extremely beneficial. And there is an anti-inflammatory benefit to IGF-1. This is a dose-related curve in units per week to IGF-1. When IGF is clearly, so if you're using IGF-1 on the y-axis and on the x-axis you have units of growth hormone, there should be a relative sigmoid curve. However, there's some evidence recently that I'm going to show you that this may not be the case. Here is a slide that I think it is worth looking at. It's the ratio between IGF-1 and IGF-BP3, and what you can see is the highest risk of cancer occurs in those with a low IGF-1 and a low IGF-BP3. So you want to be careful when the IGF-BP3 is low. IGF-BP3 seems to be immune protective. Is there an increased incidence of cancer in the acromegalic patients? The answer is no. For all cancers, there's no increased incidence. There was some suggestion in the early days that colorectal cancer may be more prevalent, but it has not borne out. Malignant disease and cardiovascular morbidity in hypopituitary adults with or without growth hormone replacement, it does not appear to have any effect on any cancer as far as we know. However, remember, myths and opinions. It's called growth hormone. So therefore, if you have cancer, it's going to cause the cancer to grow. Isn't it? Supposed to. Prostate cancer, no effect. We talked about the contraindications to growth hormone, pregnancy, malignancy. We have to respect the fact that we just don't know. We haven't taken a group of cancer patients and put them on growth hormone for a period of time to find out whether or not. So if they have an active cancer, I don't think you can safely say, I know this does not have any effect on your cancer. However, the literature does not support any relationship between the use of growth hormone and malignancies. But no one that I know of has taken cancer patients and treated them with growth hormone. So we can't say with an existing tumor that's been treated or in the course of therapy, does growth hormone enhance the likelihood of metastasis or enhance the likelihood of tumor growth? We don't know. So we use it as a contraindication to growth hormone. Past history of cancer, except for basal cell cancers, which are not affected by growth hormone. Diabetic retinopathy, because of the swelling and the edema. Sclerosing diseases of the liver and lung. The only reason you can't use growth hormone in those cases is because you can't rely on it being converted to IGF-1. Common side effects, arthralgias, carpal tunnel syndrome, edema, and occasionally glucose intolerance. Occasionally, it will have a profound effect on improving metabolic syndrome. But in some cases, especially in those that have a hemoglobin A1C above 6, it may be tricky to use growth hormone. You may have to start with an extremely low dose until you get no glucose effect. If you use the normal dosing of growth hormone in individuals who are borderline or near that type 2 diabetes level of 7 or 8, you want to be careful about whether or not it's going to have an adverse effect on their glucose metabolism. But usually, because of the benefits, it improves glucose metabolism and reduces insulin resistance. It helps patients with emphysema. Following surgical intervention, it may enhance wound healing, prevention of muscle wasting. It has a positive protein effect on metabolism. So maybe growth hormone can be used even in short terms in certain surgical procedures. There's no increased incidence or risk of prostate cancer or any other cancers, and these are all cited in the American Cancer Society, Harvard, Hopkins, New England Journal, American Cancer Society. Hormone modulation results mentally sharp, decreased resistance, physically fit, highly productive, improved libido, enhanced sexual function, better sleep, greater self-esteem. Who the hell wants to use this stuff? This is a self-report that shows energy, memory, productivity, exercise capacity, self-reporting, all improved. Why do we want to make them feel better? What the heck is going on? Here's the problem. This is our myth. This is what we believe is associated with growth hormone. However, it's true, the athletes have found a way to interfere with medicine because they found something that's good that can make their productivity better. And so the aging pitcher who at the age of 42, his shoulders are getting weak and his legs are getting weak and he can't keep up with the 20-year-old, he takes super physiologic doses of growth hormone. The bodybuilders use it to get this effect. And we in medicine, we cringe at the idea that people use growth hormone because they want to look like this. We got to make our patients feel better. We got to get over being afraid to practice medicine when we know that something is good. So what do we really know? We know that growth hormone therapy, when coupled with other total hormone modulation, complete nutrition and exercise activity, improves the quality of life, increases aerobic capacity, lowers cardiovascular risk factors, prevents osteoporosis, prevents type 2 diabetes, improves sex, and does not have any adverse effect, any known adverse effect on cancer. Why would we want to use this shit? All evidence shows that growth hormone is one of the safest drugs we have. Thousands of patients have been followed for the last 16 years. This is from Pinhas, from Cohen at UCLA. Growth hormone changes in the aging population are generally mirrored by IGF-1 levels. Here's where the myth has got to stop. Here's where you have to stop thinking that we know everything. IGF-1 levels are generally reflected of growth hormone status. Well, I'm about to give you a theory that became evident to me. Actually, the interesting thing is when they asked me what topic I wanted to talk about at the planning committee, I said, I want to talk about growth hormone deficiency and growth hormone resistance. I had no idea that was the topic of this talk until about a week ago. So when I looked at the topic, I said, wow, what is this growth hormone resistance that I made up? So I took the stimulation tests that we have done. We've done approximately 50 stimulation tests in the last 18 months with glucagon. And the interesting thing is, here's the first patient who has an IGF-1 level of 133. I don't know if this pointer works. And produced 8.9 units of growth hormone at 240 minutes. Now, we don't have to do the test that long. We do it that long. Had I stopped the test at 180 minutes, I would have had a growth hormone deficient patient. But here's what else I want to show you. Here's another patient that had an IGF-1 level of 138 that only produced 3 units of growth hormone. 120 IGF-1 level, look at the production of growth hormone. So, by definition, I have to tell this fat, lazy, dull adult they're not deficient because they produce growth hormone. So you fat, lazy adult who doesn't have any sex drive and can't think and can't sleep, you don't have growth hormone deficiency because you've grown up. So is there really an entity called growth hormone deficiency? Or have we been fooled? Here's a guy with an IGF-1 level of 236. 236. He produced 3.7 micrograms of growth hormone, so I can't use growth hormone on him. He's the same dull, fat, can't sleep, got metabolic syndrome. He's got all of the symptoms, but we can't use it because his IGF-1 level is, or because he's 3.7 instead of 3.0. So what I did is I took the 50 patients that we studied, and here's what really we found. 36 of the 50, or 72%, had an IGF-1 level below 155. 36 of the 50. So the physicians were selecting them based on their clinical symptomology, and 36 of them had a low IGF-1 level. 25 of 34 had normal growth hormone levels by 120 minutes. And yet, of those, 73% of them, 73%, had a deficient IGF-1 level. So they were producing growth hormone above 3, but they were deficient. So is IGF-1 the best marker for identifying adult growth hormone deficiency? It may be in children. And yet, here's something that I didn't know until a couple of weeks ago. Children in infancy produce incredibly high levels of growth hormone, and yet have incredibly low levels of IGF-1. So are we looking at something that 20 years ago we looked at and we didn't understand what we were looking at? Out of our 50 patients, 11 of them could qualify, or 30% of them could truly qualify for growth hormone deficiency, yet 36 of them had low IGF-1 levels. So there doesn't seem to be a correlation, at least in our hands, in IGF-1 and growth hormone production with the glucagon stimulation test. These are the signs and symptoms of metabolic syndrome, which you can relate to. Here's a comment that we spend $3 trillion in our medical care system. So that's like waiting for, people to fall off a cliff and injure themselves. When we suggest building a fence so that these people don't fall off the cliff, the answer is we can't afford it. We're spending all our money on disease. We don't have any money for prevention. We're just letting them fall off the cliff. And yet here we have a way of looking at disease that may be different. So I'm going to leave you with this thought in mind. Is it possible that there's a resistance to growth hormone rather than a deficiency? Adult growth hormone resistance has almost the exact same signs and symptoms of insulin resistance. But remember, it took us 20 years in medicine, 20 years, before we were able to say, quotes, syndrome X was actually a compilation of syndromes that we now call metabolic syndrome, and it was related to a resistance to another hormone we call insulin. People with insulin resistance produce insulin. It's just they get obese because their insulin is either there's an antibody formed or it's bound at the cellular level. We don't understand it completely, but we do understand that hormone resistance gives you the same signs and symptoms of lack. So is it possible that we're dealing with IGF-1 levels that are low and growth hormone is produced, and yet the same symptomology, increased visceral fat, high blood pressure, sarcopenia, low sex drive, diminished mental capacity, the same symptoms that we call that are related to low IGF-1 levels, and yet we're producing growth hormone? So maybe the IGF-1 isn't the best marker for growth hormone. Or maybe what we really need to do is we really need to look at growth hormone is bound at the cellular level, or it's not broken down in the liver into IGF-1. And it creates a deficiency in some individuals who are producing growth hormone, but their IGF-1 levels never rise. And without the IGF-1 levels rising, they are truly resistant to their growth hormone. Maybe they form an antibody to growth hormone. Maybe what we're calling growth hormone, adult growth hormone deficiency, is really a compilation of symptoms associated with lack of either production of growth hormone in 30% of the cases, or in 70% of the cases, inability to convert growth hormone into IGF-1. I don't know, but I know adult growth hormone deficiency never made any sense to me in the 15 years I've been doing age management medicine. And now I believe that it's time for us in age management medicine to think outside the box, to take the opinion that everyone has to fall off the cliff before we do something about it. And that the glucagon stimulation test and the insulin tolerance test and the previous arginine growth hormone releasing tests are fine for children who are dwarfs, but it has nothing to do with adults. And it shouldn't even be required, but it's being required because somebody put it in a package insert. So my suggestion is that growth hormone can be deficient in some adults, about 30% of the time. However, there are at least as many individuals with low IGF-1 levels, signs and symptoms of growth hormone deficiency, who may be producing growth hormone that is either bound, affected by an antibody, or at the cellular level it can be converted to IGF-1. It's a real potential. And growth hormone is a resistance leading to the signs and symptoms of growth hormone deficiency. They look and act the same, even if the IGF-1 levels are normal. The problem is these individuals who clearly have low IGF-1 levels and low growth hormone levels, they can be treated with growth hormone. But if I'm resistant to growth hormone, what am I going to do? Currently, there's one growth hormone secretagogue that's been studied scientifically, and it's in clinical trials right now. It's a non-peptide called MK0677. It's not commercially available, but it has promise in that it both stimulates growth hormone at the pituitary level and increases IGF-1 level. So it has the ability as a secretagogue, as a stimulant of growth hormone. So this may be one answer. We've got to find secretagogues, growth hormone releasing factors that will stimulate the pituitary to make growth hormone. But in those that are resistant, it isn't going to work. So what do we do for those people? If my theory of this hypothesis is even close to correct, what are we going to do? I think the only other thing that we can do is we can give them IGF-1. Because IGF-1 is the active ingredient and it is commercially available. It's just we are not allowed to use it because we got to wait until you're growth hormone deficient or you're a dwarf. So if we're waiting for all of the development of dwarfism in adults, then that's how long it'll take us for us to get IGF-1 to be used in a clinical setting. So I believe that we in age management medicine are at the throes of redefining the problem with growth hormone. Then in a 5-year prospective study on the clinical use of growth hormone to improve mental acuity, bone density, reduce cardiovascular risk factors is imperative in the aging population. One of the largest group of the aging population are the centenarians. And I don't know any of you who may know someone who is 100 or older, but very few of them are very active. They all have muscle wasting. They all have weakness. We could take that population of people and use them to study the benefits of growth hormone. We could study their IGF-1 levels. That's one idea. But I think that over the course of the next 5 years, if we can use IGF-1 and or growth hormone commercially, set up a prospective study on outcomes without the need for the stimulation test, because at least in our hands, and when I talk to other endocrinologists about this, they go, wow, yeah. Some of them call it secondary growth hormone deficiency. Secondary meaning the IGF-1 levels don't go up when the growth hormone is produced. Well, you can call it whatever you want. You know, fish is a fish, a hog is a hog, but this is not a deficiency syndrome, I don't believe. For the last 20 years, since 1992, when it was described as adult growth hormone deficiency, I believe we've been blinded. We've been blinded by an opinion. We've been blinded by the endocrinologists who want us to believe this is the same entity that occurs in children. And we've been blinded by not looking at what happens in nature with other hormones. Other hormones are produced and they're not effective. You heard Ed Lee talk about T4 being made but not being converted into T3. And yet those people are thyroid deficient if they don't convert T4 into T3. The endocrinologists continue to use T4 as the major therapeutic value, despite at least millions, 10 million people who can't convert it. So, what if this is right? What if this is growth hormone deficiency? And what if we can help millions of people around the world because we dump our opinion, we change our way of thinking, and we once again think, my first objective is to make them feel better. Not worry about whether or not they're going to live longer, but they're going to live better, productive lives, because I've increased their exercise, I've modified their nutrition, lowered their anti-inflammatory effects, I've decreased their cardiovascular mortality in every way that I know how to. I decrease their inflammation, and I make them feel better, because now when they get on an airplane, they can actually get out of the friggin' chair. There's a recent article in Diabetic Medicine by Mason in 2012. Most of the literature on growth hormone, by the way, comes from outside the United States. It's all in the European literature. And basically, he showed that there was a link between somatotrophic axis and the features of metabolic syndrome, suggesting there is a distinct effect of growth hormone on IGF-1 on metabolic syndrome. IGF-1 and growth hormone were significantly lower in men with metabolic syndrome, but there was no appreciable difference in men. It was in women. Women tend to have more thyroid problems. Women tend to need more growth hormone than men. Maybe we're dealing with resistance. When we talk about growth hormone resistance with an endocrinologist recently from UCLA, they feel that this is a worthwhile approach, that we could do a prospective study under an IRB protocol looking at outcomes of improving quality of life, reducing cardiovascular mortality, reducing inflammation. My God, how bad would that be if we lowered the incidence of the current level of deaths from heart disease, which is still the #1 cause of death in the United States, if we just affected that 10%? Do we really want to do that? Do we want to build the fence? Do we want to prevent them from falling off the cliff, or do we want to hang on to our opinion? Your choice. I don't know. I just know this. This is what growth hormone can do for you. And by the way, Ed Lee gets turned on by those goiters. Good luck. Thank you.